Welcome to the deep dive. Today we're looking into something really interesting, kind of an intricate corner of surgery.
Yeah, it's about spine procedures, but specifically the ones done, well, from the front of the body.
Exactly. And our roadmap for this comes from Rutherford's vascular surgery and endovascular therapy, the chapters on spinal operative exposure.
Right.
Now, you might be thinking, spine surgery, vascular surgeons, heart and blood vessel doctors. What's the connection?
That's the core question, isn't it?
It is, and that's what we want to unpack today. We're going to explore why they're such critical partners for these anterior spine exposures for interbody fusion.
Think of it like uncovering a hidden but totally essential partnership.
Yeah, for a surgery that's actually pretty common. And, with spinal problems seemingly on the rise, this kind of collaboration is becoming even more important.
Absolutely. We're seeing more, degenerative disc disease, spondylolistheses.
Which is when one bone slips forward on another, right? In simple terms.
Exactly. And interbody fusion is one way to stabilize things. Now, most people probably picture spine surgery from the back, the posterior approach.
Yeah, that's the standard image, I think.
But there's this other significant way, often with real advantages, the anterior approach, surgery from the front.
Okay, so let's get into that. Why go in from the front? What's the rationale there?
Well, the sources point to some pretty compelling reasons. Generally, it's seen as less invasive than going from the back.
Less invasive how?
Well, for one key thing, it avoids cutting through those big paraspinal muscles in the back.
Okay. Less muscle damage.
Right. And maybe even more importantly, it means the surgeons aren't operating right next to the spinal cord itself or the cauda equina.
That bundle of nerves at the end.
Exactly. That proximity in the posterior approach, well, it just inherently carries a bit more risk of direct nerve contact or manipulation.
That sounds like a really significant difference. Avoiding those nerves, less muscle disruption. What else do the sources say about advantages?
The data suggests that compared to posterior, the anterior approach often means, well, less blood loss during the operation,
Okay.
a lower need for transfusions, and sometimes even shorter operative times overall. Now, the sources are clear. There's still debate about, when and how exactly to treat back pain.
Sure, that's always complex.
But when the anterior approach is chosen, these benefits can be, well, pretty impactful for the patient's recovery.
Right, so operating from the front, but what's actually in the way? Physically.
Okay.
When you're trying to reach the spine, that's where the vascular surgeons step in, isn't it?
Precisely. To get to the front of the spine, the anterior part, you often have to navigate around or very carefully move major blood vessels.
Like the aorta, big veins.
Yeah, the aorta, the vena cava, the iliac arteries and veins down in the pelvis.
Right.
And handling those safely, that's where the vascular surgeon's specialized skill set is just indispensable.
So their job isn't the spine itself, it's creating that safe path to the spine for the other surgeon.
That's it, exactly. Their main goal is giving the spine surgeon a clear side-to-side view of the vertebrae that need work.
Okay.
This lets the spine surgeon do the discectomy, remove the bad disc material,
Right.
decompress any pinched nerves, and then accurately place the implants needed for the fusion. The text calls it achieving adequate visualization of the disc space midpoint.
So it's really a two-surgeon strategy, each focusing on their specialty.
Yes, and that enhances precision and safety.
It sounds like teamwork.
Yeah.
The sources mentioned this two-team approach. How does that actually work in the OR?
Yeah, in most major centers, it's a very coordinated effort, vascular surgeon and spine surgeon working together.
Right.
And this strategy, it's specifically designed to minimize those risks around the big vessels and really just optimize the surgical field so the spine surgeon can do their job effectively.
Makes sense.
And it probably shortens the learning curve for these tricky anterior exposures, too.
And does having that vascular expert there actually make a difference in patient outcomes? Is there data on that?
The evidence suggests yes. The text notes that having vascular co-surgeons involved is linked to measurable benefits, less intraoperative blood loss,
Okay.
shorter operating times, and even shorter hospital stays afterwards.
Wow.
The source actually calls them access surgeons.
Access surgeons. I like that. It really nails their role, doesn't it? Creating the access.
It does.
So who typically needs this kind of surgery? Are they the same patients vascular surgeons usually see for, like, blocked arteries?
That's an interesting point. Actually, no, the profile is often quite different. These patients usually have that persistent low back pain,
Right.
maybe tried other treatments that didn't work.
Right.
They might have nerve symptoms too, like leg weakness or numbness, and just a lower quality of life because of the pain. But what's notable is they less frequently have major atherosclerotic disease, that hardening of the arteries.
Oh, okay, so not the typical vascular patient profile.
No. Not typically. They often fall in the 50 to 70 age range, frequently female. Weight can vary, sometimes normal, sometimes overweight, maybe due to inactivity from the pain.
Hmm.
Though compared to patients getting posterior fusion, the ones considered for anterior tend to be a bit younger and healthier overall, probably because they need to be fit for abdominal surgery.
So even if they don't have much vascular disease history, is a vascular check still important before surgery?
Oh, absolutely. Critical. Even without significant atherosclerosis, you're still manipulating major vessels.
Right, physically moving them.
Exactly. So a thorough peripheral vascular history and physical exam are essential. Any history of, say, leg pain when walking or weird findings on their pulse exam, that needs looking into with non-invasive tests.
And what about scans, like the pre-op spine imaging? Can that show things relevant to the vascular team?
Yes, definitely. Routine scans, even without contrast, can show things like calcification in the aorta wall or even an unsuspected aortic aneurysm.
A bulge in the artery wall.
Right. And if those scans raise concerns about blockages in the arteries going to the legs, the aortoiliac arteries, or if they see an aneurysm, then more specific vascular imaging is needed, like a duplex ultrasound or a CT angiogram.
To get a better look.
Precisely. And you also need a baseline check of their pulses because, well, the retractors used during surgery can temporarily compress vessels. It's rare, but you need that baseline.
Makes sense. Are there other things in the patient's history that the teams need to know?
Yes, several things. Any prior chest or abdominal surgeries are really important
Why that?
because scarring from previous operations can totally change where you make the incision and make the dissection much harder. Like a prior low abdominal scar might push you towards a right-sided approach for a low lumbar redo.
Ah, okay. And what about previous spine issues?
Yeah, if they've had discitis, that's a disc infection, or prior posterior spine surgery, or even surgery near the level they're planning now, you have to expect more scarring and a higher risk of complications.
More difficult dissection.
Definitely. And of course, standard procedure. Patients are always counseled beforehand about the potential vascular risks, vessel injury, blood clots like DVT, things like that.
Right. Standard informed consent. Okay, so we know the who and why. Let's get into the how, the actual surgery. What are the different ways they approach the spine from the front?
It really depends on which part of the spine needs fixing. The patient might be lying flat on their back, supine, or on their side, lateral decubitus.
Okay.
For the lower back, the lumbosacral spine, our sources say a left-sided approach is common, often using the retroperitoneal space.
Behind the abdominal lining.
Exactly. For the upper back, the thoracic spine, it usually requires a thoracotomy and incision in the chest wall, and you have to temporarily deflate the lung on that side.
Wow. Okay. So maybe break that down by region. Thoracic spine, first base of the neck down to the lower ribs, roughly.
That's the area. And for the thoracic spine, the implants often go in more from the side compared to the lumbar region, so you usually need less major vessel dissection.
A bit easier from a vascular standpoint.
Generally, yes. A left thoracotomy, it's typical for T7 down to T12. Higher up, say T3 to T6, a right thoracotomy might be better.
Down the very top.
T1 to T3. Usually approached from the back, the posterior approach, unless it's a really unusual situation.
Okay. Anything critical to watch out for there?
Hugely important. Preserving the spinal cord's blood supply. There's a key artery, the arteria radicularis magna, or artery of Adamkiewicz.
Right, I've heard of that.
Its location varies a bit, but it usually comes off an intercostal artery between T8 and L1 somewhere. Surgeons have to be incredibly careful when tying off any arteries in that zone. Damaging it could be catastrophic.
Absolutely critical. Okay, what about that transition zone?
Yeah.
Where the chest meets the lower back, like T12 to L2?
The thoracolumbar junction. Yeah, that often needs more extensive mobilization of the big vessels, both abdomen and pelvis.
Some more complex access.
Can be. The sources mention different ways in open retroperitoneal, laparoscopic through the abdomen, but again, the open retroperitoneal approach seems favored.
Staying behind that lining.
Right. And if the patient's on their side, you can use things like a kidney rest on the table, flex the table a bit to help open up that space.
Got it. Then down to the lumbar and lumbosacral spine L2, down to S1. Very common area for problems. What are the approaches there?
Two main options. Transperitoneal or retroperitoneal.
Transperitoneal means going through the main abdominal cavity.
Yes, directly through it. You have to carefully move the intestines out of the way.
Sounds tricky.
It can be, especially in heavier patients or those with prior abdominal surgery scarring. And it has some known downsides.
Like what?
Potential for prolonged ileus, where the bowel is sluggish afterwards. And, importantly for men, a known risk of retrograde ejaculation.
Ah, nerve-related.
Yes. People have tried laparoscopic transperitoneal approaches to maybe lessen these issues, but the studies haven't really shown a consistent, significant advantage over the open retroperitoneal way.
So it sounds like open retroperitoneal is often the go-to for the lower lumbar spine from the front.
That's what the source material suggests, yes. It has benefits similar to retroperitoneal vascular surgery itself.
Such as?
It generally allows pretty efficient, straightforward exposure for one or multiple levels with relatively lower complication rates during the surgery. You can see the vessels, the ureters, and carefully move them aside.
Better visualization.
Exactly, which hopefully means a more complete discectomy and a better fusion result.
Can you walk us through the basic steps of that retroperitoneal exposure, say for L4, L5?
Sure. Typically, an incision on the left side, maybe oblique or up and down. Mobilize the rectus muscle, the abs.
Okay.
Then you carefully develop that plane, the space outside the peritoneum between the muscles and that lining.
Find that natural space.
Right. Once you're in, you gently rotate the whole peritoneal sac, intestines, and all over towards the patient's right side.
And that reveals.
That opens up the left lower retroperitoneal space. And there are your big vessels, aorta, vena cava, iliacs lying right over the lower spine.
Wow. Okay. And are there specific tricky bits when you get down to the lowest levels, L4, L5, or L5, S1?
Yes, definitely some anatomical points to watch. At L5S1, the very bottom joint, once you move the colon, the disc space is usually between the left common iliac vein and the right common iliac artery. You often have to divide and tie off the middle sacral artery and vein there, smaller vessels.
Okay. And L4, L5?
L4, L5 can be more challenging, especially if there's a spondylolisthesis, that slippage.
Right.
Because the left common iliac vein can get stretched and sort of flattened right over the disc space, making it vulnerable.
Oh, wow.
Yeah. And for L4, L5, it's often really crucial to find, tie, and divide the iliolumbar vein. It usually runs behind and to the side of the common iliac vein.
Why is that one so important?
If you don't divide it and you try to mobilize the iliac vein, you can easily tear the iliac vein where the iliolumbar joins it, and that can be significant bleeding, hard to control.
Yikes. So meticulous dissection needed.
Absolutely. Left to right, careful mobilization. The text also mentions sometimes doing a right-sided approach, but that means moving the vena cava, which can cause a temporary drop in blood pressure.
So left is generally preferred if possible?
Generally, yes.
During these exposures, how do they keep everything held back safely? Keep the view clear?
They use self-retaining retractors, often specific types like renal vein retractors with slightly angled tips.
Okay.
These are positioned carefully to gently hold back the vessels, the peritoneal contents, giving the spine surgeon room to work.
But gently is the key word, right?
Absolutely. You have to be super careful not to put too much pressure on things. Prolonged pressure could cause injury or even clots, especially if arteries are calcified.
Right.
The text actually recommends the team periodically release the retraction for a moment during the surgery.
Let blood flow return.
Exactly.
Okay.
Minimize pressure injury risk and also potential damage to the sympathetic nerves running alongside the spine.
Okay. Now, things don't always go smoothly.
Yeah.
What about reoperations? Going back into an area where they've done this before?
Yeah. Redo anterior exposures can be much, much tougher.
Because of scar tissue.
Precisely. Adhesions. Scar tissue can make organs and, critically, blood vessels stick right to the front of the spine. Makes dissection risky, higher chance of accidentally injuring something.
So what do they do?
Well, if they expect massive scarring, they might even opt for a different approach altogether. Maybe go from the back if that wasn't done before.
Makes sense.
But if they do go back in anteriorly, they have to be prepared for a difficult, slow dissection and a higher chance of bleeding. The sources even recommend specific sutures like polypropylene with pledgets.
Little felt patches?
Yeah, for repairing any vessel tears, because the vessel walls might be more fragile after previous surgery.
Got it. And what if the patient has calcified arteries to begin with, even on the first surgery?
That definitely increases the risk. Calcification makes the arteries stiff.
Less flexible.
Right. So retracting them poses a higher risk of tearing the artery or causing a dissection, a split in the artery wall layers. Even normally pliable vessels can get damaged if they're bent sharply by a retractor when they're calcified.
So how do they manage that?
The best strategy is usually to mobilize more of the artery, a longer segment both above and below the spine level.
Creates more slack.
Exactly. Allows for gentler retraction, less stress on the stiff wall. Might mean making the incision bigger or doing more dissection around it.
Okay.
Major arterial injuries are still rare, but if one does happen in a calcified vessel, the repair needs to be meticulous. Just sewing it up might not be enough. You want to avoid a blockage.
Right. Makes sense. So we've covered the how and some challenges. What about outcomes and complications? How common are problems related to the vascular access part?
Well, the good news is major vascular complications directly from the exposure are relatively uncommon. The sources say maybe 2% to 4% of cases.
Pretty low.
It is. And when injuries do occur, they're more often venous vein injuries, particularly tears of that left common iliac vein we talked about.
More common than artery injuries.
Yes. Though even vein injuries can be serious, especially if the patient has other health issues. The L4, L5, and L5S1 levels seem to have slightly higher rates.
Okay.
Arterial injuries are less frequent, but maybe more likely if the patient has unusual vascular anatomy that wasn't picked up beforehand.
Variations from normal.
Exactly. And there are extremely rare reports of iliac artery blockage, maybe from too much retractor pressure over time.
And if a vascular injury does happen during surgery?
Unfortunately, those patients then have a higher risk of blood clots, DVT, pulmonary embolism afterward.
Okay. Beyond blood vessels, what other complications can happen during or after the surgery?
Sure. During the operation itself, though rare, you could potentially injure a ureter.
The tube from the kidney.
Right. Or injure the bowel, very uncommon. Or even, exceptionally rarely, leave a foreign object behind. And remember, problems can also happen during the spine part, the instrumentation, the fusion.
Right, it's not just the access.
Exactly. Then post-operatively, you can see things like prolonged ileus, that sluggish bowel. Incisional hernias are possible. Rarely retroperitoneal hernias if a peritoneal defect isn't closed. Thromboembolic events, as we said.
Okay.
Retrograde ejaculation in men, sometimes temporary leg weakness, fluid collections like seromas or hematomas, lymphedema if lymphatic channels get disrupted, a really rare thing called chylorheteroperitoneum, lymphatic fluid buildup.
Wow, quite a list, potentially.
Yeah. And erectile dysfunction is another potential long-term issue for men, again due to possible nerve plexus disruption near the iliacs. Interestingly, the source says in women, it doesn't seem linked to major changes in sexual or urinary function.
Are there factors that increase the risk of these complications generally?
Yes, several are mentioned. Obesity, having had prior abdominal surgery, operating on multiple disc levels at once, reoperations, needing to remove old hardware, more blood loss during surgery, and using larger incisions, all seem associated with higher complication rates.
Okay. And after the surgery, what's the typical post-op care like, focusing on the vascular side?
Well, obviously the main focus is spine recovery and pain management, but the vascular team keeps an eye out too.
For what specifically?
Monitoring bowel function return, doing regular pulse checks, especially if the patient had vascular disease beforehand.
Makes sense.
If the patient had a previous EVA, an endovascular aneurysm repair.
Stent graft in the aorta.
Right. Some surgeons might get a follow-up ultrasound to make sure that's all still okay, no leaks.
Good point.
And then longer-term vascular things can crop up. DVT, lymphedema, maybe a surgical site infection involving vessels needs ongoing care.
And you mentioned something about veins narrowing later.
Yes, a potential late complication.
Yeah.
Symptomatic common iliac vein stenosis, a narrowing of that main leg vein.
Happening months or years later.
Exactly. It can cause leg swelling or other venous issues down the line. And it might need treatment, like opening the vein with a balloon, maybe putting in a stent.
So something to keep in mind long-term for these patients.
Definitely. If they develop leg swelling later on, you need to think about checking their pelvic veins.
This has been incredibly thorough, a really fascinating look at how these surgical worlds intersect. It really highlights the complexity, doesn't it?
It does, even in procedures that might seem somewhat routine from the outside.
So if we had to boil it down, what's the absolute key takeaway for you, for our listeners?
I think the core message is just how integral vascular surgeons are to doing these anterior spine exposures safely and successfully. They really are the access surgeons.
Yeah.
Providing that essential pathway for the spine team to work, especially as we see more need for these spinal procedures. This two-team approach isn't just helpful, it's often essential for the best outcomes.
Absolutely. A vital partnership tackling a growing need. And it makes you think, With all this intricate anatomy, the risks, both short and long term, and how technology keeps advancing, how might things like better imaging or maybe even more minimally invasive techniques change this collaboration between vascular and spine surgeons going forward?
That's a great question. Definitely something to watch.
It is. Well,
Yeah.
thank you for walking us through all that. A really illuminating deep dive.